I'm Randy Longenecker, Professor of Family Medicine and Assistant Dean for Rural and Underserved Programs at Ohio University Heritage College of Osteopathic Medicine, and I'm Associate Project Director and Community of Practice Lead for Rural Prep. I want to welcome you to the latest edition of our series of webinars intended for professional development. The title of today's webinar is Supporting Rural Programs Through Telehealth. I want to welcome our presenters, who you also see in the presenter windows, Dr. Russell McCann, Dr. Sari Gold, and Dr. Erica Shear, all of them associated with the Veterans Administration and various health facilities and telemental health programs in the state of Washington. Here's our agenda for the day. Following my introduction, the speakers will present in sequence. Again, if you have questions, please enter them in the chat box at any time, and JP and I will be monitoring those. And then when we get to the audience participation part of the webinar, I will be interacting with our presenters and leading them in a discussion of the questions you've submitted. This is a professional development webinar courtesy of Rural Prep. Rural Prep is an acronym for the Collaborative for Rural Primary Care Research, Education, and Practice, and is a collaborative across 3 universities funded by the Health Resources and Services Administration. Rural Prep's mission is to improve and sustain rural health through community engagement and research in rural primary care health professions education. And one way we do that is in developing a community of practice through webinars such as this. These professional development webinars are intended for health professions educators and researchers, as well as faculty, students, residents. And these occur 4 times a year in the months of July, December, May, and June. Always on the 4th Thursday, except for December, when we have to avoid Christmas. So this is the 3rd Thursday. You've seen these objectives in our promotional material and through registration. Most importantly, what we want you to learn today is to think of telehealth delivery and telehealth education and training as not 2 things, but 1. And consider then how you might do both at the same time in the care of patients and the experience of your learners. So at this point, I'm going to turn things over to Dr. McCann. Can you please share your screen? Thank you.
Thank you. And let me go ahead and get this pulled up here. Sorry for that. Thanks for the introduction, and look forward to talking with you all about this today. Before we get into some of the presentation, very briefly, just in terms of conflicts of interest, none of us have any financial interest or arrangements or such that would really conflict our judgments in our presentation. So just to give that to you in advance. The learning objectives were already covered on a previous slide, but really briefly, just to kind of see how this is going to be structured today. We're really covering 3 main topics. The first, which I'll be covering here in a moment, is discussing the ways that clinics really can receive mental health services via telemedicine, how basically those systems can interact, different models of care. Then we'll also go to talk about how to really engage with different telemental health systems, what types of patients are appropriate, how to really interact with these services and engage in collaborative care. And finally, we'll be talking a little bit about tele-technologies in general in terms of how to really improve collaboration, provide education, and really engage in supervisory processes at a distance. And to start things off, I'm going to be talking a little bit about telehealth systems of care. And before we get into this, I want to really define a little bit about what telemental health is. It actually is relatively a legal definition in most states. which often restricts it to video-based care. And so when I talk about telehealth or telemental health, I'm talking about using video-based technologies, much like we're using right now to meet, to be able to provide a service to somebody remotely. You'll see in the upper left-hand corner, though, of this slide, someone on a telephone. I kind of purposely grayed that slide out. I think as a little bit of a nod to often telephone is not legally considered telemental health, though telehealth often does kind of join this modality in it. And you'll see as we talk about that telephone really can be a fantastic way for providing care. Brief note, some states do consider phone to be telemental health or telemedicine. So depending on where you're located, the definition of this may shift. These other boxes that I have on the screen in the upper right-hand corner, we have an individual showing a physician on a web or on a smartphone device. The lower left-hand corner is an example of what it might look like with a patient being seated in a clinic with a provider remotely located, seeing that patient in clinic. In the lower right, we have an example of what it might look like for a clinician who's seeing a patient into his or her home. These are all different examples, really just designed to get you thinking about how this might look. As technologies are changing, you know, it's no longer such to where we have to do what's in the lower left-hand corner or even in the upper left with the telephone. We can have it to where patients are no longer seated in clinics. They can be in the comfort of their own home or other private space, even places of work. They can use devices that they may actually have with them instead of needing to be provided with technology such as a smartphone. And probably not as necessary for the audience that we're speaking with today, but very briefly, why telemedicine? Well, within the context of mental health in particular, 60% of counties in the United States don't have a single psychiatrist. And if you look at the data a little bit and more detail, within New York, you have 612 psychiatrists per 100,000 people. Compared to rural Idaho, where you have less than one psychiatrist per 100,000 people, the disparities there are quite striking. And if you actually look at all rural counties throughout the United States, there's 590 psychiatrists for those 27 million people. In other words, there's more psychiatrists per 100,000 people in New York than there are for all those rural counties combined. It's profound, this impact. It's less stark for psychology, but still quite impactful. There's 35% of US counties not having a psychologist. And this disparity is even more substantial for rural counties. The number for rural counties that don't have a psychiatrist actually goes up to 80%. So this is a major issue. I'm largely going to gloss over this slide, but as you maybe look back over this presentation perhaps later or are able to freeze this, this data really just speaks briefly to how these disparities in terms of how few providers can be in a geographical area for a certain amount of population can have an impact. These are correlations, of course, but really show how various health factors may interact with the number of providers per, say, 1,000 people in a given county, showing that people have lower levels of obesity, more physical activity, changes in smoking status, less drinking, and so on. These things hold up through a variety of very system-wide health factors in terms of things like education, also things like imprisonment and so on. So these things are quite robust, and so it matters to have access to care. So I'm going to speak to three different things. The first model is clinical consultation as a model for telemental health, integrated care model, and referral. And starting with clinical consultation, what this model of care can look like largely is that you have a network of, say, primary care providers that are able to call in or video conference in to a group to receive mental health consultation. And so the primary care providers can call in, get feedback on a case, and with that feedback, really develop skills to be able to manage various mental health presentations on their own. An example of this, and I'll have examples for each of these on each of the slides, is the University of Washington Psychiatry and Addictions Case Conference, or UW-PAC. This is available for free to people within the state of Washington. They can dial into it and be able to get psychiatric consultation. What they see with this particular thing is that providers tend to call in more frequently earlier on in the process and taper it off over time as they develop competence. And then over time may just call in less frequently as needed. So this is a great model of care. These things can be scheduled on demand. You can have it where someone calls in at a specific time. There are consultative services that, as needed, say in an emergency department, a case comes up, that you could call out and be able to get that on the fly as well. Integrated care, you basically have this model where you have a primary care system on site, and off site you have various mental health resources that are available. This might include care management, which would often be RN. And this person does symptom monitoring, some education, assess barriers, and will work on self-management goals. All the while, either the PCP or case manager could refer for counseling or psychiatric services as needed, which are located off-site. The patient's location in these models can be really variable. They can be seated in the clinic where the rest of the services are being provided. The patient also could be located at his or her residence off-site or other private location. And so there's a lot of flexibility of how this can look. Some models for this, the Fortney et al. 2013, that's a paper. And this functions as a hyperlink here that you can use with the slide. This paper really has a model for this, shows how it was really effective in terms of getting people access to care. And you really can have a smaller group of providers that manage care at multiple sites at the same time to really be efficient. This HRSA Telehealth, and again, I have no relation to these people, and I'm not here to vouch for their services. This, though, is an example of a private entity out there that does offer this sort of thing, and sites can contract through these organizations to provide such services to their sites. This is a brief visualization of what integrated care might look like, where the care manager often is connected with the patients over the telephone. Psychologists, social workers, psychiatry are often using video-based care to connect with patients. And all the while, the PCP, care management, counselors, and psychiatry are all interacting with one another in a collaborative manner. The last model to speak about before I pass this along to Dr. Gold is about referrals. So the models I've talked about so far are where a primary care is reaching out, getting consultation, or is engaging with an entity that provides service from a distance. You can also just refer. And if you don't have providers in the community where you are to give these services, there are telehealth services that can be beamed in, so to speak. And so these services don't need to be provided to a clinic. They can be delivered to another private location, such as someone's home. There are some limitations to this. There is some law out there right now called the Ryan-Haight Act, which will be kind of avoided in the future. But for now, what this basically means is scheduled substances can't be prescribed at a distance unless they have had an in-person visit first, or are delivering that service to a DEA registered facility. So what types of patients might be seen through this may be limited in some ways. And this, again, not something I'm affiliated with, but Insight Telepsychiatry is an example of a service out there that does accept referrals from providers to basically expand one's referral base. Feel free to ask questions about these models and other ways of doing telepsychiatry, and I will pass this off to Dr. Gold. Thank you.
Okay, can everyone see and hear me okay? Okay, I am here to talk about consultation and collaborative care, specifically how to interface well with telemental health providers and how to make appropriate referrals for that service. So one thing for you to know when thinking about referrals to telemental health is the research thus far really suggests equivalence in care between telemental health and face-to-face visits. And that the research has found equivalence of care or non-inferiority with respect to diagnosis and assessment, with respect to psych meds, and with respect to psychotherapy. And various different types of specific evidence-based psychotherapies like cognitive behavioral therapy, prolonged exposure therapy for PTSD, et cetera. The research also has generally found that offering telemental health tends to reduce cancellations and no-shows and decrease the cost of services. And we are going to talk about appropriateness for telehealth, but I just want to make sure that it's clear that assessing for appropriateness is ongoing, that sometimes a patient might be appropriate now, but might not be in a month or two. So it'll be up to the telemental health provider to keep assessing and making sure it's the right treatment modality. So in terms of inclusion criteria, telemental health is great for folks who are experiencing barriers to care. So things like distance from a clinic, physical limitations like paralysis or, overcoming, healing from surgery, that kind of thing. Folks with childcare issues or with transportation difficulties. You'll want to make sure the patient wants this service, that they state that it's a preference or that at least some willingness. You'll also, though, want to be thoughtful about avoidance. In terms of mental health, there are certain presentations like agoraphobia or social anxiety disorder where telehealth might be, it might end up being a provider colluding with avoidance as opposed to helping a patient overcome it. So you'll want to be thoughtful and talk through that with the patient and make sure the patient's on board with working towards overcoming, whatever that avoidance is. And you'll want folks with some familiarity or comfort with technology. They don't have to be experts. At least with our program, they get training from a technician, but they need to at least be willing and comfortable enough to use the technology. So in terms of exclusion criteria, we will want to make sure that the telemental health service offered is the appropriate level of care. So for example, dialectical behavior therapy or inpatient care, if folks need dialectical behavior therapy, for example, that is not necessarily, it's not that DBT can't necessarily be provided over telemental health, but our particular service has 3 psychologists. So DBT involves group, individual therapy, phone coaching, so it just wouldn't be an appropriate service for our team to offer. So you'll just want to make sure that the patient's needs match up with what the telehealth team offers. You'll want to be thoughtful about patients with active hallucinations or delusions related to technology. So if a patient is receiving messages from a computer, then doing therapy or psychiatry over a computer could be challenging. And you'll also want to be thoughtful about patients who have symptoms that could be difficult to observe over telehealth. So things like eating disorders. If you're needing to monitor for, dehydration or monitoring someone's weight, for example, that would be hard to do over telehealth the way it's set up now. If a patient's engaging in self-harm, it'll be harder to look at things like cuts or burns over the computer. If there's interpersonal violence in the home, the confidentiality could be a concern. If someone overhears a session, could that create safety issues for that patient? And, alcohol or substance abuse, if the patient needs, UAs or some sort of monitoring like that, that's not available to that telehealth team, then it might not be the best line of care. And then I saw some questions earlier about sensory limitations. So if there are some workarounds for hearing difficulties, but if a patient has pretty severe hearing difficulties or visual impairments, they may have difficulty managing the technology. And when you're referring a patient for home-based telemental health, so the telehealth into the patient's home rather than to a different clinic, you'll want to be thoughtful about privacy. Does the patient have privacy in their home? Or is the computer in a public area of the home? You'll want to talk through child care issues, because especially like an intense trauma-focused therapy, you're not going to want a child in the room. So can a neighbor come watch a child? Can a child, be in front of a screen with headphones for the hour-long session? You'll want to make sure the patient has an email account. At least that's the program we're using. A patient, in order to join the call, needs to click on a link in an email, so they need to have email and know how to use it. You'll want to know if the patient has a computer, high-speed internet access, webcam in their home. If they don't, the VA is now issuing iPads that have data plans, so it's not a requirement, but it's good to know whether the patient needs that or not. And then the other consideration is the patient requesting care out of states. We do sometimes get snowbirds here in the Pacific Northwest who, spend part of the year here, part of the year elsewhere. And there is this great anywhere to anywhere legislation that has passed that gives a lot of protection to VA providers who are seeing veterans in other states. However, there are some states who are not in agreement with this legislation, and so it is a little tricky to provide care via telehealth to a state where you're not licensed. So the telehealth provider will just want to be thoughtful about risk factors and whether or not they're comfortable with doing that as this kind of new legislation continues to get worked out. And when you're introducing the concept of telemental health to a patient, it's really good to think about the language you're using. So you'll want to describe it as cutting edge, and not use language like it's kind of implying it's second rate or it's just because you live far away, but really convey confidence in the modality and make sure the patient's on board and interested and willing to at least give it a try. And in terms of ongoing work with the telehealth providers, one thing I would say is just keep in mind technology is always changing. So I know there are some equipment, for example, that have breathalyzers. We don't have it right now, but the equipment available to us will probably change over time. So it'll just be good to check in. At some point we may have a dialectical behavior therapy team able to up and provide telehealth to folks. So just kind of be in touch, and the research also is constantly changing. There's more and more data to look at in terms of adapting care to tele and how effective it is. And so I would just really encourage ongoing open communication about these services. And I am done.
There we go. I couldn't find the mute button. Hi, I'm Erica Shearer, and I'm going to round out our talk by talking a little bit more about the training piece and how to infuse technology into our education and supervision systems. Let's see here if I can get my slides going. There we go. So with regard to education, this area of research is very robust. It's growing all the time, and more educational systems are incorporating technology in various degrees into their programs. Oh, I have the presenter screen with notes showing. Let's see if I can change that. How about now? Is this better? Okay, thank you for that alert. So what we're finding is that more and more trainees, supervisees, and folks in general are considered digital natives, in that this is the environment that they are used to. This is the channel of information that they're used to. I remember back in my school days, I was used to pen and paper, and it took a lot to learn to edit documents through Word or whatever program, and to track changes and so forth, because I was so used to just scribbling things out and writing in that way. And increasingly, people are moving away from that and using technology. And so we have to kind of adapt to the system. And part of what Russell and Sari were talking about is that our technology increases and moves at a rate that is much faster than perhaps our own personal preferences, the legislative systems, and so forth. So we kind of have to be able to be flexible and learn to adapt. So typically with technology infusion, we're thinking of blended instruction models. Some folks call this flipped instruction models, where an in-person environment is supplemented with technology, even things like PowerPoints, videos, and above, as well as fully web-based instruction, distance learning, and so forth. Okay, so I think blended learning makes sense. It's pretty face valid. There's been quite a bit of research on it. And most people think of this as the best of both worlds, because you've got the in-person instruction as well as the cutting edge technology. But we want to be cautious with that, because what we're finding is, you know, it's not all the same. And so we want to take the research with a grain of salt. Just because one person is using a PowerPoint to supplement their talk may not be the same as using some of the digital skills and interactive components as part of the homework and infusing technology that way. And one is not better or worse than the other, but we want to be really thoughtful about how we're using technology. And the same with web-based interventions. Of course, there's a lot of advantage to having everything be online and available. We saw this in some of Sari's slides and Russell's slides, but really that dissemination piece, the cost piece, the access piece. But perhaps another is that the content can be standardized for students, as well as tailored, which is an interesting kind of piece that's coming about more and more, these interactive components to technology. And then another big part that we certainly see in the mental health arena is that there may be less avoidance related to stigma. So there was an interesting chat comment about acceptability of telemedicine and telemental health for you know, other cultures, other areas, rural populations. And I think that's an area where we're still figuring it out. On the one hand, perhaps those populations may not have as much access to the technology, although as Sari mentioned, the VA is working on getting iPads out. Of course, the iPads are limited by the data connection, right? So here we are in Washington, and there's parts of the state that don't have good data access. So we're still needing to work out all of these kinks for sure. But the research has shown that there's consistently a positive effect. Now, web-based learning is not typically in the research areas, you know, it's not typically a controlled design where you're, you know, having folks in a web-based classroom environment matched to an in-person one. It's typically looking at web-based alone. So again, taking that with a grain of salt. So taking this all together, it's pretty well received, but we really want to think about our audience, and that traditional classroom instruction and web-based instruction may not actually be true alternatives or opposites to each other. There may be factors related to the audience, the type of people that choose to be in a web-based instruction or have to have web-based instruction only, that may be part of this picture as well. And so similar to what we find in the clinical field, it's not really the platform. So it's not online or not, technical or not, but it's really the content that's being delivered that might be most important. So with telemental health, as Sari was talking about, the kind of spiel that you give to patients, it's not so much the technology piece, but being able to see the person that your provider, the connection, and being able to receive care, and that the technology can kind of fade away as you continue on with treatment. So in contrast, telesupervision is a very new area of research. It's still very much a burgeoning area, but similar to what we've talked about before, there's great potential, particularly with relation to access. So what's interesting for trainees is that trainees tend to stay and become employed in the location that they're trained. And so if we're thinking about geographical areas of healthcare shortage, being able to offer training at these locations and offer telesupervision or teleconsultation might assist with the recruitment and retention of needed healthcare professionals. So we certainly want to think about that as we move forward. And then the other piece is by having those providers that are in the rural communities be able to offer telesupervision and consultation, perhaps to trainees or professionals who are in more urban areas, then we get to learn from the real experts that are there, boots on the ground in these communities. So an example that I refer to quite frequently through working with the VA in Honolulu is that they have their trainees provide care to really remote islands such as Guam and Saipan, and they get to have supervision from a supervisor there on the island to do that. And there's great benefit to that because there's a real tribal structure there. There's a lot of factors related to what services are possible, what the community is like, that a provider or supervisor that would be in person in Honolulu may not know or fully grasp. So keeping that in mind as well. So like I said, the literature is still growing. It's primarily focused on asynchronous technology. So that synchronous would be in real time, what we're doing right now, whereas asynchronous would be email or text as an augment to supervision. And there has been some research on group supervision via CBT, which is clinical video telehealth, what we're doing here. So far, there haven't been a whole lot of differences in satisfaction, supervisory working alliance, the effectiveness or self-efficacy of trainees. So it really parallels the research on telemental health and mental health delivery. So some feedback, just as a summary of the literature thus far, is that within a group supervision context, other supervisees felt a connection with others in the group, and that paradoxically, that the limited visual cues that were imposed by this modality increased the emphasis on really being clear with the verbal content, and that may have actually improved supervision processes. Similarly, there was a greater emphasis on staying on task and being really clear with feedback. Of course, there were challenges related to technological difficulties, a lack of training in the technology in specific, and some thought it might have been important to have some kind of relationship prior to telesupervision. So right now, the APA, which is kind of what Russell, Sari, and I are familiar with, being on the psychology side of things, it does support up to half of the supervision requirement to be met via telesupervision. So for individual supervision, that would be 1 hour or less per week, or 2 hours or less of total combined group and individual supervision per week. It's notable that the VA currently does not permit telesupervision as a general principle. However, there have been 2 programs that do have waivers to be able to provide telesupervision because of their geography, Honolulu being one of them. So just some kind of take-home guidelines if you're considering telesupervision. It's helpful to have a very clear policy that does adhere to existing regulations. So things like how are emergency procedures handled, what's the protocol for accessing a supervisor, how do patients access supervisors, definitely having clear instruction on the technology, lots of room to practice, to problem solve tech issues, what's the tech support like, and then perhaps thinking about the goodness of fit and readiness of supervisees. So having your supervisor be remote may require that the supervisee is perhaps more of a self-starter, perhaps more proactive about their own supervision needs and how they avail themselves of their supervisors. On the other side, there's also a goodness of fit of telesupervisors. thinking about how they make themselves accessible and available, how flexible they can be with the modality, their expertise with the population and or the technology. And then another piece of this is considering how live observation and supervision can be met. So we use a lot of bridge call type technology, or similar to this, where there are multiple entities in one virtual medical room. And that facilitates a lot of live observation and supervision, just like an in-person kind of setting would allow for. So kind of the big take home with education and Tella supervision is the modality is more flexible. Technology is increasing and changing all the time, but it's how we think about what is important with our in-person care and then translating that to this modality to be optimally effective. So that ends my portion. I think we left plenty of time for questions and comments. So I think, Randy, we send this back to you. Is that correct?
That is correct. And thank you very much for your presentations. You've walked us through a big picture review of what telehealth is, from consultation to referral. You've talked about some things you need to be aware of and which patients may or may not be appropriate. And we've talked about the integration of telehealth and education. And you ended on the note that I'd like to start with. And that is, I, in medical school, had the wonderful experience of interacting with the patient and having someone behind a one-way mirror observe my interaction, and they could, in the moment, even communicate with me if necessary. Can you tell me, is that what you're thinking of or describing as telesupervision?
I can speak to that. Sorry, again, this mute button is so tricky for me. So I think the main difference with live observation via telesupervision is that everyone is visible on the screen, at least with the technology that we use. Now, the VA has specifics with regard to what kind of technology we use for patient care. And that's just a small window into all of the technology that is available, of course. But typically, it would either be something like a group setting where folks kind of look like Hollywood squares on the bottom, and whoever is talking, it takes the large screen, and the telesupervisor would be one of those people in there, kind of a co-facilitation type model, with the telesupervisor gradually sitting back more and more in the group session, much like an actual in-person group. And the same would be true for one-on-one sessions, or having a supervisee sit in on a prolonged exposure session, for example, having them just be one additional square. So it's not so much the person behind the screen, which I'm familiar with graduate school as well.
Yeah, so the supervision we're talking about could be supervision of a group of learners, or even one learner talking about a patient they saw an hour ago, or it could be an actual observation of the primary care physician interacting with their patient as the psychologist watches. We have a question from someone who teaches medical students, third-year medical students in North Dakota, and was wondering, how might you integrate students into the therapist-patient relationship in a telehealth encounter? You have some ideas about that? And feel free, any one of you, to respond.
I'm happy to, but I want to get, yeah, go for it, Sari.
Is it getting the primary care provider with a mental health provider, or is it just is it medical student in general?
Well, I'm thinking that you might be doing a telehealth, a telemental health consultation with a patient in North Dakota. And it just so happens that the patient is in a clinic where there's a medical student who knows the patient and knows that they are being referred to you. And they just want to sit in, almost like shadowing, or they might even be available as a Tella interpreter. I want to get to the question someone else asked about Tella interpreters, but they could even be the Tella interpreter with the patient. That is, they're the person who's in person present with the patient, and you as the therapist are off-site. Any thoughts about that?
I think that's a very common model that we do a lot with our rural community-based outpatient clinics. I want to say CBOC because in VA land we have an acronym for everything, of course, where I like the word teleinterpretation. We call them telepresenters, where we often will have nurse or medical staff in the room with us, and it helps to take blood pressure, to take all kinds of assessments, and to also be the bridge. So a lot of times with rural patients, there's a lot of ambivalence related to someone on the screen from the big city is going to come talk to me about my problems. Who is this person? And so having someone to advocate for telehealth and to be able to say, hey, we want to give you the best care possible, and that means putting you in contact with the person over here who has an expertise in PTSD or depression or whatever it is, and to actually facilitate that connection can be very helpful. And I think with the medical student, that would be one example, to have them in the room with the patient while we're on a screen. Another one might be to have a medical student here with me who wants to learn more about rural veterans and coming in that way. Or another one would be to have a medical student perhaps in North Dakota, I'm in Portland, and the patient is in Mount Vernon, Washington, and have us all together. It kind of makes the distance fade away. And we do what we're calling shared medical appointments quite a bit, where we'll have, in my insomnia class, for example, I'll have a psychiatrist talk about all of the different sleep medications. The patients are in a different setting, they're in a different setting, and I'm in a different setting. So it's really interesting to think about all the possibilities.
Yeah, lots of possibilities. And some medical students, of course, function as scribes at a very early stage of their medical education and training, and they could, in fact, function in that way. Any other thoughts, Dr. McCann?
Yeah, thank you. I think just to add to that and just maybe really emphasize that how this could work really depends on the context. There's so many different combinations for how this could show up. And in a lot of ways, I think depends on the services that might be offered and interact with the site. And, for example, could just be a consultative service that's available. And you could imagine, as Dr. Shearer was saying, there's many ways as if somebody could listen in and experience that process. Or on the other end of the spectrum, it could be a complete referral out, in which case it could be an education on how to place such a referral and to leverage those sorts of mental health resources. When you don't know of a provider in the community, here's how you could find one digitally. And then some sites too, they offer, say, services within the site, but they may have, like, say, a standalone psychologist like myself, and I'm hired on to provide care just for one site, and I'm really a part of the staff there, in which case I can develop that rapport and be able to really integrate these sorts of learning things into the care I'm offering. But sometimes you have multiple providers for serving multiple sites, and it's really this kind of team-based approach that's dispersed over a large geographical multi-site area. So really, I don't think there's a good answer for this. I think in terms of one size fits all, I think there's a lot of opportunity. You don't even need to be with the resident. You could be remote. They could be in the same room as you or the patient. The possibilities really are endless, which gives a lot of nice opportunity here.
Excellent. We have another question about Tella Interpretation, and I may be misunderstanding the question, but my understanding of the question is, what about the use of a learner as a Tella interpreter? We sort of touched on this, but in a very intentional way, because, for example, the student or resident physician may very well know this patient quite well. They may be their continuity patient, may have known them for 2 or 3 years and are in their final year of training. It's almost like welcoming them into a co-therapy kind of situation where the resident actually functions as a co-therapist with the remote specialist, if you will. Is that what you understood from the question? There are also, of course, language interpreters. There are people with visual or hearing impairment who may need an interpreter with them in the room.
And that's, I think, the latter there is kind of what I was thinking. So I don't know for the person who asked that question if it's possible to clarify. Certainly with with literal interpreters, this actually has come up before, where we have kind of questions about this sort of a thing to be able to get that in. A lot of phone-based services, of course, people probably have heard about this, where you actually can dial in and the two individuals talk back and forth with one another as if they're just talking, and their interpreter does the intermediary work. Certainly a possibility over telehealth. I am not actually as sure how often this is done in current practice, though. It's a fantastic idea, and I think in a lot of ways, things like that are just enormous opportunities where things could go and maybe haven't really taken off as much yet. But there's lots of availability for it. You could certainly have the interpreter join a video appointment using a landline, so it can be kind of a mixed modality connection. And so that certainly would work, much like the phone-based interpreting work can be done today, but I've not heard instances yet of video-based interpreting joining in.
Several years ago, we had a full day devoted to some of the ethical issues that come up when learners are introduced into the doctor-patient relationship. And I'm thinking in mental health care and tele-mental health delivery, introducing a learner might have some ethical ramifications. What ethical ramifications can you think of?
Well, certainly this, and I think there's almost even a little bit of almost an added level of discomfort or anxiety that can arise for a patient when technology is inserted in. There's fears about, and even if not well thought out, it's just, well, the security of this line, and is anyone else listening in? Is this being recorded? This sense of you're being watched, and sometimes just having an actual human being in that room kind of personalizes it a little bit more. I do think that adding this tele component to it can kind of raise that a little bit more for patients. Though I would probably caution on assuming too much that patients would experience that to be the case, because what we've seen in literature time and again is things that providers often are concerned about, such as, oh, I won't be able to establish rapport with this patient, or the supervisory thing is going to be an issue. Generally speaking, patients tend to be satisfied with the modality and tend to be okay with it. And so I think it's good to be aware of it. Maybe as you're talking with patients about it, speak to the technology a little bit to try to maybe reduce or mitigate some of the concerns they might have. But I think also kind of not relaying an expectation that this is something you need to be worried about or concerned about, that almost treating it as this is a normal way to be able to provide services, I'd say.
As in a live interaction with the patient, you have a student with you. There are times when the student does need to step out And it seems to me making that explicit at the beginning of the visit is important.
Absolutely. And I think we're used to hospitals being training settings or having that kind of spiel. And I certainly remember, I think at least in our program, it's often this trainee kind of discussion you have with a patient to say, I'm a trainee, I'm not yet licensed. This is my supervisor who is monitoring everything I do to ensure I deliver optimal care. Can we talk about recording sessions or having them sit in on sessions and really establishing what the patient is comfortable with in the get-go? And similar to what Sari said about patient appropriateness for telemental health, that can be an ongoing and should be an ongoing conversation with the veterans and so forth. And we have that quite a bit, talking about PTSD and trauma and really difficult subjects that they may at one point say, you know what, I think I want to be with someone who's not a trainee and just, one-on-one there, or actually I still feel comfortable with this or not.
We have a question about the evidence that patients able to participate in a relationship like this from the comfort of their own home makes them accept it maybe more quickly than they might in the VA clinic. Any thoughts about that?
Yes, I would say we definitely see that, especially think of folks who we have a lot of, medic trauma, right? So folks who come to the VA, or military sexual trauma patients, right? So they come to the VA and it's such a triggering environment that if we can see them in their own home, it can make it feel, it's eliminating some barriers for them and help them feel a lot more comfortable. I usually try and have that explicit conversation with my patients, like, I'd love for you to feel comfortable at the VA. This is your medical care, you earned it. And so we incorporate that and might do some exposures to going to the VA. But yeah, I think it definitely really helps to have that option and to be able to do a lot of therapy before getting to the exposures, to work up to it.
Well, we're getting lots of questions now, and I'm having trouble keeping up with it. One question catches my eye, and that is, are you aware of any instances where resident physicians are being supervised by mental health providers long distance, as in providing the supervisory function in residency training?
At long distance, unfortunately, I am not. I am aware of certainly resident supervision that does happen, does include the telehealth modality, and sometimes there's a little bit of distance between the provider and the resident, but I think in general there typically always is that opportunity for, I think, that in-person sort of environment, as I've seen so far. I think one of the biggest things that often comes as a barrier to this is kind of these systems issues, like the law. Sometimes the law literally requires some in-person care, or sometimes it doesn't specifically address whether or not video-based care would be okay. So I think in a lot of ways what we're seeing is that it's a really developing area. We're seeing the law in different states kind of handle these things differently. And I think they're starting to relax way more to allowing for this. But until that happens, it's I think there's a little bit of a uncertain area where it hasn't been well taken on.
Well, thank you all very much for this webinar today. We have a lot of questions that remain, and I'm going to suggest to these individuals that they send their questions to us, and we will get them to you guys. We do have contact information at the end of our slides today. But I'm going to just move ahead. I want to let you all know that, if you could advance the slide for me, Tippy, that we have our next professional development webinar in May. We've not yet decided the topic for that. But in the time between now and then, we will be doing our Rural Prep Grand Rounds. And if any of you are interested in participating as sites, here are the topics that we're going to be addressing. This is a team-based learning event, and so you have to participate as a site. You cannot participate as an individual. Next slide. Also want to alert you all to our micro-research opportunity. The next call for proposals for this research funding for learners, for students, residents in primary care will be opened in May. And I just want to alert you to that, since that will happen before our next webinar. Next slide, please. We really are interested in your feedback as to today's event, and anything that you might want to message to us about how it worked for you today, any additional questions or suggestions. If we were to do this again in the future, we really appreciate that. If you just click in the chat box on the link that you are given, then you can give us your evaluation, or you can type this address into your browser, those of you who may be watching this asynchronously at a later date. And then finally, I want to just leave you with contact information for myself, as well as Davis Patterson, who is the project director for Rural Prep, and Dave Schmitz, who's the dissemination lead. We'd be happy to take your questions individually, or if you just have a general question, send it to rprep@ruralprep.net. So thank you again very much for your participation. Just to make sure, yes, the link to the evaluation is in the chat box. If you'll just mouse over the lower part of your screen and open the chat box, you can click on that and it will take you immediately to our evaluation and survey. Thank you again so much to our panelists for your wisdom and participation in today's event. And wish you all happy holidays and good luck with innovating around telehealth. Thank you.